Thank you. Thank you very much. And good morning to everyone. I think most of you probably have met at some point or know you. So I don't think much introductions are required. Okay, so today we're going to be talking about spine and fluoroscopy in particular. But I figured there's no point just going into fluoroscopy without just a quick recap of spine and really why it triggered my interest. And I'll cover a little bit about the ultrasound stuff that many of you know that I have done before, and then we'll move on to the fluoroscopy side. So spine pain, very, very common. I'm sure you see it all the time in the clinic, whether it's low back pain, thoracic or upper back pain. And actually, it's going to become more and more prevalent as the years go by, particularly because this is basically the position that we're all adopting. And even now, as I'm sitting here in front of the computer trying to give you this talk and I'm trying to maintain a good posture, I can feel my shoulders dropping down, my neck moving forward. So as we age in this, this age of sitting in front of the computers, we're all going to start developing low back, neck and shoulder pains as a consequence of poor posture. And I think the prevalence of back pains is going to increase significantly in the future, and also I think we should be upping our management in terms of how we address these things. So it wouldn't be a talk on sports medicine or fluoroscopy or ultrasound if we didn't touch base on some of what might be potentially important clinical anatomy. Now, one of the things I've seen a lot in practice is when patients come in with back pain, they automatically think, oh, it's my disc. And certainly the disc can be a contributing factor to pain symptoms. However, as we all know, there's many different types of triggers for back pain. And I'm just going to cover some of these in a brief while. So we have obviously the disc, we have the muscles, we have the joints, and we also have the ligaments. And I think if I can convince you of anything at the end of this talk, that the ligaments are important, hopefully you'll go away and you'll have a new perspective on back pain, which I did some years back. But let's start first of all with the disc. As we know, there's hyaline cartilage there. It can be a significant contributing factor for low back pain. If you look at some of the work out there, actually, it does tend to happen at a much younger age than we believe. And you usually have these episodes of mildly traumatic lower back pain, rugby tackle, somebody got, somebody fell down while they were doing something, and symptoms will typically resolve after a few days. But what typically happens after that, that's the starting point, and then you start getting the breaches in the disc, and then you start getting the annular fissuring and the protrusions and come after that. So this is if you've not come across this paper, it's quite an old paper by Sizer et al., but I think it's a really great summary of back pain. And if any of you are at all interested, I'm more than happy to ping it across to you. But I think it gives a really nice, succinct way of looking at back pain, and it covers lots of the different pathologies that I started to become very interested in after leaving KTP. So obviously we have the normal disc here. We have areas after injury where there's areas of end plate separation. We can have end plate fracture and then complete separation as well. And these can all lead to symptoms of non-specific low back pain as well. But when we're talking about the tears and the fissures and so on, this is where the annulus becomes weaker. You get the nuclear material kind of migrating outwards a little bit. And in essence, we can think of two types of disc protrusion or disc bulge. It's essentially we have the shoulder here, or we have the axillary, and it depends on where it's pushing on the nerve. So the shoulder is very much in the central portion and it's bulging out, and on the axillary it's kind of pushing on the medial border of that nerve as it's coming outwards. Another thing that is commonly causing pain that I don't think maybe we're considering so much are the facet joints. But to be honest, I feel that the facet joints are probably more common as a cause of back pain as opposed to the discs. In the facet joints, when you typically get pain with extension, and when you bend forward, you typically offload them. And you will often find patients who have facet joint related pain. They'll come in and they're sort of in this stooped position, or they'll be using their arms to get out of the chair. There can be localized pain as well, but there can also be radiation. And part of that is because the facet joint sits so close to the exiting nerve that actually inflammation in this area can cause nerve pain as well, as much as the disc can. And so, this is a slide that I used many years back in a GP talk, and it was just a way of kind of trying to explain to primary care physicians as an easy differentiator in terms of considering between low back pain related to facet joints and discs. And so, it's just a useful tool that you might want to kind of share with people. Coming on to the joints in a little bit more detail, of course there's joints at all levels, and as we come down the levels, they tend to rotate outwards a little bit. When the disc height changes, as it gets smaller, that you tend to have this increase of load on the joints, and as a consequence, you can also get different asymmetries in the loading of those joints based on where the disc changes are happening as well. Just as another way of thinking about the joints, and I think this, reading some of the literature and the papers around it, really made me sort of start to think of the joints in a slightly different way. I mean, essentially they're articular joints, and they have this capsule which surrounds it, and the outer part is much more stiff, and the inner part is quite flexible, and it's a bit more like a meniscus. And I don't know if you've ever noticed, but when you have patients with facet joint pain, when they're bending forward and then when they're coming up, they get that sudden sharp pain, and it sort of stops them from moving. And essentially it's this catching of this inner lining of that joint, which is effectively like the meniscus. And so as they are moving, this inner lining part will catch between the inferior and the superior articular process, and that will cause sudden pain in the back, and that will stop them from moving temporarily. Sometimes actually this can also be the trigger of their pain symptoms as well. And so, I think this is very relevant in terms of assessing patients with back pain. And if, like I said, you are at all interested, please let me know, and then I'll share this paper with you. When you're looking at the MRI, and it wouldn't be a talk on back pain without throwing in a few MRIs, you can actually start to notice the facet joints a little bit more. So here we're seeing the inferior articular process of one level and the superior articular process of the other. And if you start to look at this in a little bit more detail and with a bit more interest, you start to notice significant changes. And this is what I was talking about before. So here we have a disc, we have the foramen here, and you can see there is narrowing as well. But you can already see that there's significant degenerative changes in those facet joints as well. And as these facet joints get irritated, they get inflamed, there will be that inflammatory process going on around here. And so even in patients with degenerative disc changes, it's very useful to consider the facet joints. And it became another area of interest for me as I sort of moved through dealing with more back pains over the years. Ligaments. Now, this is something that we hardly get anything reported on when it comes to our MRIs, but I think this is very, very relevant when it comes to the back pain. There's a whole host of different ligaments supporting the back, and we often consider ligaments in the ankle, in the knee, and we are always saying that, oh, you've injured it, you've sprained this, you've torn that, and that's why you have the instabilities, and that's why you're having the symptoms that you're having. You go for ligament repairs, you go for PRPs or Prolotherapies to the ligaments, and all the while there's all these ligaments that are in the back, and yet we aren't really considering any of them. And the reason that I started to consider them was because over the last couple of years, I've moved into looking at pain a lot more, and interventional pain. And these guys are really on the ball when it comes to ligaments. So the key thing with the ligaments is that as much as in the knee and the ankle and so on, you can injure them, that you can injure them in the back. And without these supporting structures, the muscles have to then tend to do more of the work. Okay, and instead of having a 80-20 relationship in terms of 80% of the time there for movement and 20% of the time there for more postural work, it goes to a 60-40 to a 50-50, and in essence, the muscles are then having to do more of that work. If you're then asking the patients to go for rehab or different treatments, needling, acupuncture and so on, and you're trying to relax the muscles, actually we're doing our patients a disservice, because on the one hand the muscles are tight because they're trying to keep the posture and keep everything together. On the other hand, we're trying to relax them and strengthen them and make them work even harder. And so if you're not dealing with the underlying issue, which is the laxity of the ligaments, it's not really going to work. And my take home I want you to think about is, that last time that, you may have fallen down when you were a kid, or where if you've ever been in a car accident and you've had that sudden deceleration, acceleration, all of these kind of forces are affecting those ligaments, and they're spraining them and damaging them. And so cumulatively over time, these ligaments will become looser, they'll have tears and everything like that. And if you're not dealing with those, are you truly dealing with the underlying back issues? And if you look at the diagrams and images of the back, there's so many supporting the spine, and yet are we really dealing with these things? If you look again at MRI scans and so on, these are the ligaments here. I mean, they're huge structures, and they go all the way up and down. The interspinous ligaments, the intertransverse, the posterior longitudinal. And okay, yes, I appreciate that some of these things we're not able to reach to treat, but the more superficial ones we should be considering and should be treating. And certainly that's what a lot of the pain doctors are doing in Europe. But then there's a little bit more, and the reason I put this in is because I think we have to start to think of things not in isolation but in combination. So the disc and the zapophyseal joints will create a triangle. Okay, it's a triangle that kind of depends on each other. And at the front you have the disc, and on the sides you have the joints. And basically, an issue in one will cause the others to compensate as well. In flexion, the disc controls the angular motion, and the joints affect the kind of ventral motion, and in extension, it's the other way around. And basically, this is what it is. So we have this triangle, we have this almost tripod, and if the disc is starting to wear out, then the joints are going to start to take more of the load. If this joint is worn out, then these other two structures will take the load. And so if you do see a pathology in one, it's always really, really important to consider the others. And then finally, let's look at SI joints. Now, SI joints, I think, are a lot more prevalent in terms of low back pain and leg pain than we give it credit for. And patients who have SI joint pains can present with pain sitting down. There can be pain radiating down the leg. There can be pain even radiating further up the back. And sometimes in patients who have this non-specific low back pain, I think it's really useful to go and have a look at the SI joints. And certainly when I was at the hospital, we had a patient who came in with Angst-Bond, but it wasn't Angst-Bond in the SI joint sense, it was angstbond, which presented with glute med tendinopathy. And then when we went and looked back at the SI joints, there was certainly changes there as well. So the SI joints present quite a challenge, and it can be treated quite effectively with different treatments.